the last talk of the day. It revolves around sleep-related movement disorders and sleep-related issues that we call as parasomnias. We're going to do a case study here. A 10-year-old girl in the clinic complains of an uncomfortable feeling in her legs that gets better when she moves her legs. And she was recently, or not recently, 2 years ago, was diagnosed with chronic renal failure. And this feeling keeps her up at night. And mom had read about restless leg syndrome in an article, and she wants your opinion. 5 possible options. So what do you need next to make a diagnosis of restless leg syndrome? You need a sleep study, just a history is enough, or SIT, or suggested immobilization test, where a child sits and you record the child sitting for at least 30 minutes and count the number of times the child moves. Check serum ferritin level, which is the iron stores, and CBC with hemoglobin. Those who in favor of A, B, C, D, or E. I think an over-explanation of C confused a lot of you, but restless leg syndrome is a clinical diagnosis. All you need is a combination of 4 things in the history, and that's your diagnosis. And those 4 things are an acronym, URGE. The first one is an urge that makes a child move their legs, and it's usually uncomfortable. Rest makes it worse. So the history would be the child sits and watches TV with the parent, and it's got constant movements, and it's like a worm in their pants, something like that. And getting up and taking a walk makes it better. Stretching their legs makes it better. Rubbing on their legs makes it better. And it's usually worse at night. So these 4 things constitute the diagnosis of restless leg syndrome and differentiate these from other causes of leg discomfort, including growing pains. About 2 to 4% of all children have restless leg syndrome. There's a long list of differential diagnoses. Mostly, the most common diagnosis or differential diagnosis is growing pains. But as a pediatrician, when I was trained, I used to diagnose kids with growing pains all the time, but I was never trained in asking these 4 questions. So that's where I realized that this is the best platform where I have some pediatricians in the hall to discuss this thing. So growing pains, the difference would be there's not going to be any diurnal variation. It's not going to be evening exacerbation. Movement or rubbing on the legs or taking a walk is not going to make it better. And there's usually no family history. In restless leg syndrome, most of the times there is a family history. So since you have diagnosed this child with restless leg syndrome successfully, what would you do next? Just follow clinically, prescribe clonazepam, obtain a nerve conduction study, obtain serum ferritin level, prescribe Benadryl, or suggest melatonin. Those in favor of D are right. Next step is checking serum ferritin level. And this is the other confusing aspect, because once you get the ferritin level, the lab will tell you any number between 7 and 300 is normal. And I hear pediatricians telling me, it is normal, it is 9, it's perfectly normal. It's not, because any level below 50 is considered clinically significant in a symptomatic child and needs to be treated with elemental iron, 3 milligram per kilogram, or 65 or 130 milligram per day. Other treatments, because once you put them on iron, it's going to take 4 months to see an improvement. That's how slow iron builds up. So in the meanwhile, there are some other options, including clonazepam, or Klonopin, clonidine, gabapentin, your adult medications, ropinirole and pramipexole, which is usually not recommended in children, but it's an algorithm. Sometimes that's the only thing that works. Or opioids. In pregnant women and teens, opioid is the first-line choice. So this is just a copy-paste from UpToDate, just to give you the impression of ferritin. Ferritin less than 50 is abnormal. Doesn't matter what the lab tells you. A recent study that looked at treatment of restless leg syndrome, 97 kids participated in it. Average ferritin level in all those symptomatic kids was 22. 70% of them had less than 30. Response to treatment with iron, 80%. The mean time to see an improvement, 4 months. So you got to be patient. In the meanwhile, you have to try different things. Start with melatonin. I would jump to gabapentin next. Or if it's severe, causing nighttime disturbance and child is erratic, hyperactive, tired during the day, I have prescribed clonazepam. Comorbidity of restless leg syndrome. 65% of individuals with RLS have a psychiatric comorbidity. In children, 25% of kids with RLS have ADHD. 1/3 kids with ADHD have RLS. In my clinic, when I see children with ADHD, I almost always screen them for iron deficiency because there are studies proving that if you treat restless leg syndrome, severity of their ADHD is going to get better. And there's a neural mechanism behind it. It's that iron is a cofactor in the production of dopamine, which is a common denominator between RLS and ADHD. Every ADHD medication you know is a dopamine agonist. And how do you treat RLS? Dopamine agonist. They're pramipexole and ropinirole, those strong dopamine agonists, but different pathways. By replenishing iron, you are correcting or elevating concentrations of dopamine in both of these neural pathways, nigrostriatal pathway and corticofrontal pathway. There are 5 times more likely to be depressed and 13 times more likely to be anxious, kids with RLS. High prevalence in chronic kidney disease and sickle cell, and the reason is the same, relative iron deficiency. So we have covered one of 6 movement disorders, sleep-related movement disorders. Moving on to the next one, let me play this video for you. This video is made by a mom who stands next to this child's room and videotapes him. And every 20 seconds, he does that. And he's asleep, by the way. So every 20 to 30 seconds, somewhere there, he moves his legs. So based on the history of sleep disturbance, we call him into a sleep lab. We do a sleep study. And we see these blimps every few seconds. And important thing here is that his breathing is okay, effort is fine, heart rate is normal, a couple of PVCs though, but EEG shows no disturbance. So this child is sleeping seamlessly. There is no arousal, but he's constantly moving. So these are called periodic limb movements of sleep. It's a sleep study-based diagnosis. Most people think this is restless leg syndrome, which is not true. This is PLMS, periodic limb movements of sleep. So we count these leg movements in a set of 4. So 4 PLMs, or 4 leg movements, make 1 PLM. So there's 1, 2, 3 PLMs in this view. So what you do is, you count these leg movements and you divide over the total sleep time, you get a PLM index that gives you an idea of how busy this child is moving in their sleep. Because EEG is fine. This child is going to be rested mentally in the morning, but physically, it's going to be tired. It's a lot of work to kick your leg every 5-10 seconds. So PLM index of 5 to 10 is considered mild, 10 to 30 is moderate, over 30 is severe. So what do? Sleep is fine. He came in because mom thought he was not having good quality sleep, but he is having good quality sleep as seen on the sleep study. The child is otherwise asymptomatic. So I would screen them for restless leg syndrome because 70 to 80% of individuals with restless leg syndrome have PLMs of sleep. And when you ask them the question, and they would say yes to all those 4 questions, that yeah, my legs bother me in the evening. When I move them, it kind of feels better. And sometimes it keeps him from falling asleep. Still, I don't have to treat it because it's not bothering him that much, but I can at least check his ferritin and replenish iron. The other side of management is screen them for ADHD, depression, anxiety, and so forth, and refer them to psychologists like Lindsay to help them out with their issues, because high likelihood, 13 times odds ratio for anxiety and 5 times odd ratio for depression, that is significant. Most of the time it's undiagnosed. Studies have related having PLMs of sleep with increased risk of hypertension, stroke, and mortality, just because of sympathetic outflow during sleep. Every movement causes some degree of tachycardia. In the picture that I showed you, there were a couple of PVCs, just to give you an idea about the sympathetic overstimulation. So that was our second of 6 sleep-related movement disorders. Third one.
How is my mom?
So 3-month-old baby, mom brings him in for having these movements always in sleep. Questions to ask would be, do they always happen in sleep? Do they stop when mom wakes them up? And does anything else happen with these movements? Does he stop breathing? Is he snoring?
Logan, stop it for a minute.
So this is your benign sleep myoclonus of infancy. As the name indicates, pretty benign. Happens in the first 6 months of life. These are repetitive myoclonic jerks. Can happen up to 6 months of age, and only during sleep, and they stop when they are woken up. And there's nothing else besides this that could cause it. For example, seizures. Neonatal myoclonic epilepsy can present like this, but most of the time those kids are awake. But it can still happen during sleep. So EEG is the best test to differentiate between the two. So this was a video sent by a mom, and that's how I spend my weekends. So this is a sleep-related rhythmic movement versus sleep-related rhythmic movement disorder. Difference? Well, there are certain kinds of them. There's head banging, body rocking, mixture of the two. It becomes a disorder if it interferes with sleep, causes impairment during the day. Child is more cranky the day after he had a lot of head banging, or it's injuring the child. Child is doing it so loudly that it seems like it's going to injure him. That's when you call it a disorder. They're considered normal. They go away by 3 years of age. Just have to reassure the parent and remind them to ignore them, because if they don't, it ends up being a communication device between mom and the child. Every time the child bangs their head, mom comes in the room, so it becomes a communication, two-way communication. So it should be ignored. Only 5% do it by the age of 5, which means 95% they remit. I've seen 16-year-olds doing it, coming in just for that. And the reason why they came in is not that they're bothered or anything, is that they're embarrassed because they're going to college and they have to bang their head every time they fall asleep. So how can I help them? So usually sleep aids. They had tried melatonin, but I tried a tricyclic antidepressant like amitriptyline that took care of it. And if you see a child in your clinic who comes in with any kind of body rocking, head banging movement, screen vigorously for sleep apnea or restless leg syndrome. The youngest I diagnosed a child with periodic limb movements of sleep was 3 days of age to mom who was anemic. Baby was anemic. Mom had history of restless leg syndrome. Baby was having these rhythmic movements, which was thought of seizures, but we did a study and found out they had periodic limb movements. Gave them iron supplements. So same way, screen them for restless leg syndrome and screen for seizures. Big clinical pearl here, during seizures, eyes are always open. If something is happening and their eyes are closed, chances are it's not seizure. But if their eyes are open, refer them to neurology, or at least get an EEG. All right, so the last one, movement disorder. A child comes in with headaches and fatigue. You do a sleep study, and you see this. And when my sleep techs see this, they think it's a seizure, but it's not. And it's going with something that the snoring mic is capturing. It's faster in frequency than the breath. The number of breaths are 4. The number of movements are 7. It's not a snoring sound. Turns out this is how bruxism looks like on a sleep study. So teeth grinding in children. The diagnosis of bruxism based on American Academy of Sleep Medicine criteria, there has to be evidence of abnormal tooth wear with combination of, that's when it becomes clinically significant to American Academy of Sleep Medicine. When they have jaw pain, muscle tightening, headaches, or jaw locking, or something like that, or a crepitus in their jaws, that's when it becomes clinically significant. And I refer them to dentists to take a look at that. But bruxism, as somebody asked after the first talk, teeth grinding is a very consistent sign of sleep apnea or sleep disturbance. Anything that disrupts the continuity of sleep is going to exacerbate bruxism or teeth grinding. So if you hear worn out tooth as a dentist, or you as a pediatrician, you hear a mom telling you that grinds his teeth in his sleep, screen them for sleep apnea clinically. Ask questions about snoring, choking, gasping in sleep, continuous movements in sleep, or the child ever complain of legs hurting. It could be anything that could be disrupting the continuity of sleep. So that completes our list of 6 or 5 sleep-related movement disorders. Next, we move on to parasomnias. Parasomnias are defined as nighttime behaviors or experiences that are unpleasant or unwanted. Based on when they happen, they're divided into non-REM or REM parasomnias. This is a sleep architecture as we discussed in the first talk. If you divide this 8 hours of sleep into 2 halves, you'll see the first half is predominantly non-REM, or stage 3 sleep. The second half is predominantly REM sleep. So classically, if you see a child or a parasomnia presenting in the first half of night, chances are it's going to be a non-REM parasomnia. In the second half of night, it's probably going to be REM parasomnia. This is just a inference from sleep architecture. Let's look at non-REM parasomnias first, in the order of being less complex to more complex. Most common, confusional arousal. That's where a child wakes up confused, talks something totally irrelevant, and falls back to sleep. Diagnostic hallmark, they do not leave the bed. They stay in the bed, say a few things, fall back to sleep. That's confusional arousal. Very common, 17% of kids have that. Peak age, 3 to 13 years of age. Second, more complex, sleepwalking. They just get out of the bed, leave the bed. That's where it turns into sleepwalking. Take a walk, do a few non-purposeful things. Some kids go urinate in the closet, or they open the door and walk out of the house. And worse, they walk out of the window. And something that differentiates sleepwalking from night terror is that during night terror, there is excessive sympathetic outflow. They're sweating, they're panicked, they don't make any sense. They're scared about something, but you cannot console them. And they have no recollection of any of these in the morning. So non-REM, not remembered. It's a little mnemonic to remember. REM sleep parasomnias, always remembered. The most complex non-REM parasomnia is sleep-related eating disorder. Most common presentation, somebody's been cooking food in my house, or has been eating candies in my bedroom, and I've gained 20 pounds. They have no recollection of that they're doing this, but they eat usually high carb, unhealthy things, sometimes inedibles, raw meat, and so that's your sleep-related eating disorder. So all of these are non-REM sleep disorders or parasomnias. They will not be remembered, but the take-home message is, once you hear a non-REM parasomnia, there is some degree of expectation, yes, it's going to happen in kids. But when they become persistent, when they become recurrent and frequent, that's when you need to question if they have an underlying sleep disorder, and parasomnia is just a symptom of that. Underlying sleep disorder, just like we mentioned, sleep apnea, restless leg syndrome, periodic movements of sleep, or medication side effect, like caffeine or a stimulant. Night terror, I'll just give you a couple of things, which is episodic, abrupt terror, usually starts with a scream, and with intense fear and autonomic arousal with no recollection during the day. There are factors behind it. Predisposing, it takes a certain kind of child, usually genetic predisposition. Priming, sleep deprivation, the most common reason for parasomnias or frequent parasomnias. Sleep deprivation. So always establish a good sleep history. When does the child sleep? When do they wake up? How much sleep they're getting? That's your quantity of sleep. Next questions would be about quality of sleep. So that will be your OSA, PLMD, and medications. The thing that you or I will have to treat or address beforehand is safety, because they are likely to get into situations that could be dangerous. They could fall from the stairs, they could walk out of the house, they could jump out of the window, or grab some sharp object and injure somebody. There have been 3 homicides in history that have been blamed on sleepwalking and night terrors, combination of these 2. So first thing, safety. Alarms on the windows and doors, toddler locks on the drawers, hide the sharp objects. A child is able to do certain automatic things that they're used to doing during the day during sleepwalking. They can open and close the door, but if there's a combination lock, they can't do it. So my number 1 fix is that round doorknob thing that you have to press on both sides and twist it to open the door. Just install that, and they will not leave their room, because that's a problem-fixing type of thing that you cannot do while half of your brain is asleep. This is to keep them in the room. But if you want to keep them in the bed because you're worried that they will get out of the bed and bang themselves into the walls, I have them sleep in a sleeping bag that needs to be unzipped using a maneuver. So they will wiggle and fall back to sleep, and injury is prevented. Work on sleep hygiene. Avoid caffeine, especially in the afternoons. Work on sleep habits, scary movies. 5 Nights at Freddy, that's something that pops up again and again in my clinic. Watch out for that. Sleep extension. Just like today, all of you sacrificed your Saturday morning sleep to be here. It's a big sacrifice. I really appreciate that. But that's a very, very protected time for every child, because during the week, they are already kind of sleep deprived every day a little bit. So Saturday morning and Sunday morning is their catch-up time. That's how they pay back the sleep debt. If anything is waking them up on Saturday or Sunday morning, soccer practice, hurry to get on electronics, anything of that nature, you need to keep track of that and put an end to it. And again, finally, screen for other sleep disorders. REM parasomnias, I'll touch on 2 of those. One is nightmare disorder. So it's going to happen in the second half of the night. Child is going to remember every detail of the dream. It's going to be a little unsettled, but won't be frantic or running around in the house. They would need to be reassured. And there is a link between having nightmares and having slightly anxious personality, or having anxiety, or having adjustment reaction with anxious or depressed mood. Treatment, again, is reassurance, CBT, biofeedback, and image rehearsal therapy, which is when a child describes cognitive behavioral therapy. The child describes their repetitive dream, if it's repetitive, and you just change the ending of it. That's what they're doing for veterans who are coming from abroad and having repetitive PTSD dreams. They're using image rehearsal therapy. They're just changing the end of their dream, and that's taking care of their PTSD nightmares. Medication-wise, prazosin is something that really helps with PTSD nightmares. And for every night a different show kind of nightmares, it's gabapentin or clonazepam. Last one is REM sleep behavior disorder. In other words, dream enactment. If a child or even a grown-up tells you that they have been enacting their dreams, they were dreaming about running, and in real life they were running, or they were fighting somebody and they wake up and they're punching their bed partner, that's your RBD, or REM sleep behavior disorder. In grown-ups, it's a predecessor of certain neurodegenerative disorders, like alpha-synucleinopathies, dementia with Lewy body, MSA or Parkinson's. 13 years averagely before the diagnosis of these conditions, a typical patient starts to have RBD. So this could be a red flag for that. But in children, the etiology is completely different. It has to do with certain brainstem malformations, like in Chiari malformations or Joubert syndrome, or they may have narcolepsy, or it's strongly linked with autism or Rett's syndrome. That's what I see in my clinic, at least the most common, autism and Rett's. So that covers our lecture for restless leg syndrome, sleep-related movement disorders, and parasomnias. Well, I thank you all for coming and joining us.